Um, so it's hard to follow up such an excellent talk as what Gavin just gave, but I hope to be able to do so in a few years when our transfusion study is done. What I've been asked to do today, here's my disclosures, which also haven't changed since a few minutes ago, is to quickly provide a comparison of plasma, plasma derivatives, and factor concentrates, specifically focusing on cryoprecipitate and PCCs, and talk a little bit about their pros and cons of perioperative use. Although it has already been pointed out today, there really isn't a lot that has been published in the randomized controlled trial data. So just in terms of comparison of the agents, just to remind you, here's a list based on the type, plasma, cryo, PCC, and then single factors, which I'm actually not going to talk much about. Their constituents, again, plasma has all the clotting proteins and some other stuff you might or might not want. Cryoprecipitate, we predominantly focus on fibrinogen, but remember it has factor 813 and von Willebrand's factor. PCCs I'll talk about in a moment, and single factor concentrates only have one factor. And again, they go from high to low volume when you're giving a dose. Reminder that some centers do cross-match cryo and others don't, whereas there's obviously no cross-matching required for the concentrates. And then the constitution or preparation time, again, goes from long to short. Risks, kind of potential viral transmission, but theoretically no viral transmission with these, and different risk profile there. So we heard earlier that most people are moving away from plasma transfusion during cardiac surgery or looking at alternatives. And I just put these two studies up because they were two recent ones that, again, are on different sides of the debate about whether plasma affects mortality in cardiac surgery. One saying yes and the other saying no. So this study from a couple of years ago looked at the long-term survival of patients who received either no plasma or a lot of plasma during cardiac surgery for during coronary artery bypass. And you can see that there was a survival difference between patients who got no plasma and those who got a lot of plasma, and when they tried to correct for other confounding factors, they still saw a difference in terms of higher mortality. This other study from the French group, the Plasma Card multicenter cohort, said that plasma transfusion doesn't reduce 30-day mortality in patients undergoing cardiopulmonary bypass with excessive bleeding that they defined as more than 4 units of red cells. And here's their survival curve for 30 days. It actually does look like there is a difference. That is, the plasma group had a lower absolute survival, and that was true on univariate analysis here. FFP transfusion was associated with a significantly higher hazard ratio, but when they were adjusted for a variety of factors, the hazard ratio was still greater than 1, but it lost its significance. And what was significant in terms of predicting mortality here was Euroscore and also some preoperative coagulation abnormalities, and then transfusion of red cells. So the plasma issue they felt was confounded by these other issues, and it's not the plasma that killed the patients, it was their risks or their other transfusion parameters. So the focus has actually shifted, as you know, to component therapy rather than giving the whole kitchen sink or the whole bag of plasma. And part of it is related to changes during cardiopulmonary bypass. This is Kevin Karkoudi's study where he looked at a variety of coagulation factors prior to and after cardiopulmonary bypass. And you can see that fibrinogen concentration was the most significant in terms of decrease. There's also obviously a significant decrease in the platelet count and in prothrombin. So the focus has shifted really into coagulation factors, fibrinogen, or the PCC coagulation factors. So when and how should low fibrinogen be treated? Well, the trauma guidelines recommend 1.5 to 2 grams per liter. most people say, well, in vitro studies suggest that greater than 2 grams per liter is required for effective clot formation. And many guidelines now suggest that 2 is an appropriate trigger. So you can calculate the fibrinogen dose required to give you the rise in fibrinogen concentration. But essentially, about 3 grams of fibrinogen would produce a 1 gram per liter increase. And to do that, you need 1.5 to 2 liters of FP, 8 to 10 units of cryo, or 3 grams of fibrinogen concentrate. So as I said, I'm not going to talk much about fibrinogen concentrate, but I am going to talk a little bit about cryoprecipitate, because that is one of the ways that we can increase fibrinogen concentration. And this is a study from South Korea where they looked at the recovery and changes in fibrinogen-based clot firmness after giving cryoprecipitate in patients having deep hypothermic circulatory arrest for aortic surgery. So this shows the plasma fibrinogen concentration at baseline, weaning after reversal, and then after the administration of 10 units of cryo if their FibTem A10 was less than 6 millimeters. And you can see that administering the cryo at this point did successfully raise fibrinogen concentration, not quite above 200 milligrams per deciliter, and that there was a significant variability in the ability to raise fibrinogen concentration. And when they looked at the plasma fibrinogen and FibTem variables, they calculated, well, first of all, the absolute increase in plasma fibrinogen was variable, 39 milligrams per deciliter. And when they looked at what they called the in vivo recovery, that is percent of fibrinogen that they thought they were giving to the patients, it was only 61%. And this relates to what was already mentioned in an earlier session, that is the variability in fibrinogen concentration in cryoprecipitate. In this study, they looked at several units, and you could see the variability of fibrinogen concentration from this unit to that unit. And they also, in this study, reported variability in fibrinogen concentration and fibrinogen content from a variety of different authors. This is that particular study, and then several other authors, and you can see, again, a tremendous threefold range in the fibrinogen concentration of cryoprecipitate in these studies. Now, some would say that, well, the variability doesn't matter because if you don't get the desired response, you can always give more. So as I said, I'm not going to talk much about fibrinogen concentrate because Ravi's going to talk about it, but this was the one study that was mentioned, 61 patients with moderate bleeding after aortic surgery who were randomized to rotum-guided fibrinogen replacement versus placebo with protocolized transfusion. And their primary endpoint was number of allogeneic units received within 24 hours. And there was a significant reduction in the patients who got fibrinogen concentrate compared to placebo. As I say, I'm not going to talk about fibrinogen concentration anymore, or fibrinogen concentrate, because Ravi will do that. I'm going to move on to prothrombin complex concentrates. This slide shows you several of the preparations that are available. And they, as you know, we divide them into 3-factor concentrates or 4-factor concentrates based on the amount of factor 7 that's present in these preparations. There are some other things present in prothrombin complex concentrates. Specifically, heparin may be there, and that may be of interest in patients with heparin-induced thrombocytopenia. And I remind you that PCCs are preferred to plasma for urgent warfarin reversal. Here's another classification of PCCs, just to show you one other factor, and that is we talked about the 3-factor versus 4-factor PCCs, but there is also an activated preparation, the FIBA, factor VIII inhibitor binding assay, which contains activated 2, 7, 9, and 10, and protein C. Okay, this is the study that has led to the change in guidelines for urgent reversal of vitamin K antagonists. They took 216 patients with acute non-surgical bleeding and randomized them to get 25 to 50 units of factor IX equivalent of PCC or 10 to 15 mils of fresh frozen plasma. And again, this was a 4-factor PCC, and they looked at the fraction of patients who did not correct their INR. That is, as you go down, these are patients who corrected their INR up to 28 hours or 24 hours after the infusion. So you can see the PCC people very quickly corrected their INR, and the FFP people took a lot longer. And the median duration of therapy was also significantly different, 17 minutes for PCCs versus 148 minutes for the FFP. And within 30 minutes of the end of treatment, again, there were more patients who achieved the target INR of less than 1.4. So this is the reason that we now use PCCs for, or those of us who do, use PCCs to urgently reverse warfarin. Now, there really is not much in the literature, in the published literature, even though many people use PCCs, looking at the effectiveness of PCCs in reducing bleeding. This is one of an early study, and it's just a retrospective study of 77 patients who got PCCs during their cardiac surgery, some of whom also got FFP. And this represents the chest tube, postoperative chest tube bleeding for patients who got PCCs compared to those who either got FFP or in some cases PCC and FFP. And they suggested that the patients who only got PCC had a lower amount of chest tube bleeding. In terms of reported trials with the activated form, the only one that I'm aware of is this one by Howard Song, looking at 25 patients who received FIBA as rescue therapy in patients who had coagulopathy after cardiac surgery. And so they looked at their pre and post dosing coagulation profiles, and you can see they were able to normalize the INR, not so much the PTT, and really no change in fibrinogen. And when they looked at blood product use, first of all, the mean dose of FIBA was about 2,000 units, 2,100 units. When they looked at transfusion of FFP before and after FIBA, there was a significant reduction. And similarly, in platelet transfusion, there was a significant reduction in platelet transfusion after administration of FIBA. But again, an observational trial. And as was already brought up this morning, there is concern about thrombosis with activated PCCs. And in this trial of 25 patients, they did actually report an upper extremity DVT in a patient who had an ICD and a central line in place. So this is a brief report in the Canadian Journal of Anesthesia from one of the other Toronto hospitals, just showing how some other people use PCCs. And in that, instead of giving plasma, if one gives PCCs and cryoprecipitate, especially in patients with acute right ventricular failure who may not be able to tolerate volume, you can replace essentially all of the coagulation factors. So this is what's in plasma, this is what's in PCC, this is what's in cryoprecipitate, and this would be in the combination of PCC and cryoprecipitate. You can essentially replace what's in plasma except for factor 5 and factor 11. Again, in Sunnybrook and several places, they use this instead of using plasma. We've already heard this morning that the PCCs are used for reversing NOACS, DOACs, or TSOACs, new oral anticoagulants, direct oral anticoagulants, or target-specific oral anticoagulants. And this looks at comparing using a variety of agents to reverse either Dabigatran or Rivaroxaban. So here's factor 7, here's PCC, and here's activated PCC, looking at a variety of things. Do they correct volunteers' coagulation tests, their thrombin generation, whether they improve animal models of bleeding, and whether there are any human studies to suggest there may be benefit. We already heard that factor 7 is generally not very good at reversing either laboratory tests or otherwise for these agents. PCCs predominantly for the anti-10A inhibitors. For Dabigatran, it's a little bit less convincing. And the activated forms, again, in laboratory and clinical settings, the suggestion of giving activated forms is that they may be more beneficial at reversing, although there is a concern that they may actually overcorrect the thrombin generation with them. So in terms of suggested dosing for reversing of these target-specific oral anticoagulants, a couple of this is a slide board from a couple of hematologists from Hamilton. PCC is suggested a standard dose of 2,000 units, or if you want to do a weight-based, you could use this. And the rationale for a standard dose of PCC is that most of the inhibitors are not weight-dosed anyway, and so heavier persons will have a lower plasma concentration. And so you don't need to replace the PCC with a weight-adjusted dose. In terms of the ABCCs, the activated forms, the recommendation is start low because of the concern with thrombosis. And here you're having a bypassing effect rather than a placement. And start low because of the concern about hypercoagulability. And just a reminder, 50 units is at the lower end of hemophilia treatment if you're using this to treat hemophilia. There is some upcoming data related to PCCs for these agents. There are observational or cohort styles for PCCs and anti-10A inhibitors in Sweden and Canada, and there's a cohort study in Canada for activated forms for reversing Dabigatran. And as was mentioned, there are specific antidotes being developed, either target-specific or non-specific antidotes for these agents. Okay, we also heard a bit about point-of-care testing, and part of the reason to do targeted therapy is that we may be able to use point-of-care testing to better target these agents. This is one that was mentioned. Klaus was second author, looking at either standard lab test guided therapy or viscoelastic testing guided therapy for fibrinogen, PCC, and FP. And as you know, the results were very positive in terms of transfusion, and specifically if you look at FFP, there was a significant reduction in FFP transfusion with this algorithm, and a significant reduction in factor 7A administration, and also a significant reduction in mortality. This is the study that was referred to, that was just published last month in Anesthesiology by Kevin Karkouti in Toronto. A single-site study where, again, they developed a less complicated algorithm which was based on weighing the sponges to see if there was how much bleeding there was. And if there's no bleeding, you don't give blood products. And then if there is bleeding that's not massive, then you give targeted therapy, here platelets, plasma, or cryoprecipitate. And in this study, here's the transfusion outcomes. There was a significant reduction in red cell transfusion, a significant reduction in platelet transfusion, and a significant reduction in plasma transfusion, and also in large volume transfusion, and again in the use of recombinant factor 7A. Interestingly, there was no difference in cryoprecipitate or fibrinogen concentrate or PCC in this study, but again, in Toronto or in Canada, the use of these agents has been quite low, so it's not surprising there wasn't a reduction there. And it's interesting to look at the time series analysis, which this was, because this is their proportion of erythrocyte transfusion prior to the intervention and then after the intervention. This is for all comers, and this is for high risk and low risk. So you can see the dramatic effect of the intervention in terms of reduction of transfusion. In some cases, the reduction is sustained. In other cases, the reduction is not as well sustained. And it's also interesting to see that the low-risk patients, the trend before the intervention was to reduce transfusion anyway, but it's specifically in the high-risk group where there seems to be maximum effect, maximum benefit. So this is for erythrocytes here, this is for platelets here, and this data is for plasma transfusion, all comers, high risk, low risk, and for large volume erythrocyte transfusion, again, all comers, high risk and low risk. So, and also what's mentioned, there is now an ongoing multi-center trial in Canada to look at the implementation of an algorithm like this to see if it reduces transfusion of essentially all blood products. So why not just replace blood products with concentrates or replace plasma with the other alternatives. As I pointed out, there really is very limited efficacy data, even though lots of people are using these agents. There's very few good head-to-head comparisons. There's concern about safety and thrombosis, and in Canada, cost is a big issue as well. The ESA guidelines in terms of management of severe perioperative bleeding, they recommend the implementation of coagulation and transfusion algorithms, since they can reduce transfusion-associated costs in trauma, cardiac surgery, and liver transplantation. They suggest goal-directed therapy with concentrates. They also recommend considering prophylactic infusion of fibrinogen, since it may reduce bleeding in cabbage surgery, and they recommend fibrinogen concentrate guided by point-of-care monitoring. And finally, they also recommended factor VII may be considered for patients with intractable bleeding. Some of the members, people in this audience, have taken a different view of those guidelines, and they said that further studies are necessary to better define the use of point-of-care devices. They also said that fibrinogen level to be targeted and outcomes with fibrinogen should be better studied in well-designed trial. They also said the existing body of literature is not large enough to clearly exclude the risk of thromboembolic complications, and they felt there was too little evidence for the support of preoperative fibrinogen supplementation. So I'm going to stop by concluding that coagulation factor deficiencies are common in perioperative patients. There is correlation with bleeding and adverse outcome. I think it's quite clear that PCCs are the preferred agent for reversal of vitamin K antagonists. There's emerging data about fibrinogen replacement with cryo or fibrinogen concentrate, and for PCCs for perioperative hemostasis. And I think we still don't know the optimal use, safety, and cost benefit of these agents. Thanks.